Everyone. Welcome to 5 Mark Short Note series. Today we will discuss about episiotomy. So episiotomy is a planned surgical incision made on the perineum to enlarge the vaginal opening during the second stage of labor. In modern obstetrics, episiotomy is preferred only very restrictively and it is a part of evidence-based use. Episiotomy is actually a surgical incision made on the perineum or posterior vaginal wall during childbirth. It is done to facilitate fetal delivery to prevent severe spontaneous perineal lacerations. So, what are the anatomical things we have to consider? One is vaginal mucosa, next is bulbous spongious muscle, then superficial transverse perineal muscle, perineal skin, and occasionally fibers of the external anal sphincter if extended. What are the types of episiotomy? There are four types of episiotomy. First is mediolateral type, where the incision is made at 45 to 60 degree from midline, where there is less risk of voices and but there is more pain, bleeding, and slow healing. Then there is midline episiotomy. So here the straight posterior incision is made. Here there is less pain and easy repair, but there is a high risk for anal sphincter extension. Then there is lateral episiotomy, where starts 1 to 2 centimeter lateral to midline and avoids perineal body and may injure Bartholin's duct. Then J-shaped insert in episiotomy. Here there will be downwards lateral curved where there will be more space, difficult to repair and risk of rectal injury. So these are all the types of episiotomy. The first is median episiotomy, which is done here. Then the mediolateral episiotomy, which will be here. Then transverse episiotomy. Then J-shaped episiotomy. What are the indications for episiotomy? It is not a routine procedure. It is done selectively under specific conditions. The conditions for maternal indications include rigid perineum, delaying delivery, previous perineal surgery, fetal pelvic disproportion in borderline cases, maternal exhaustion, shoulder dystocia to reduce severe laceration in women at fetal indications include fetal distress during rapid delivery, preterm infant to reduce pressure on the delicate head, breech delivery, and instrumental deliveries include forceps and vacuum extraction. Obstetric indications include vaginal delivery, need for more room for manipulation, and there is a risk of uncontrolled perineal tear. Regarding the timing and technique of episiotomy, it is performed during crowning of the head when perineum is stretched and done during contraction to reduce blood loss and allow controlled incision. It is done through infiltration with the local anesthesia, 1% midline. Then two fingers are inserted to protect the fetal head. Incision made during contraction and crowning only. The suturing is done layer by layer postpartum. First vaginal mucosa, followed by muscles, followed by perineal skin. Complications. The immediate complication is bleeding due to injury to the branches of pudendal artery, extension of the incision into the anal sphincter, that is third degree tear, into rectal mucosa, which is fourth degree tear. Pain and discomfort followed by hematoma. The early postpartum complications include infection of episiotomy wound, wound gapping and dehiscence, urinary retention due to pain, dyspareunia in the early postpartum period. Late complications include dyspareunia, chronic perineal pain, scar tenderness, rectocele or pelvic floor weakness, then fistula formation where there is very rare but severe complication if infection or tear extension occurs. Prevention of complication. Avoid routine episiotomy, adopting restrictive use only. The proper angle, that is mediolateral episiotomy, is preferred. Adequate anesthesia and asepsis precautions has to be done. Skilled suturing with appropriate technique and post-procedure analgesia and hygiene advice are compulsorily to be given. Management of the complications. If there is bleeding, identify the source, ligate and resuture the pudendal artery. Hematoma, observe if it is small, evacuate and ligate if it is large. Antibiotics, drainage, and sitz bath has to be given if there is any suspected infection. Control the infection and delay the resuturing. And in case of anal sphincter injury, layered repair, stool softness, and pelvic physiotherapy has to be given. If dyspareunia occurs, a pelvic floor therapy, lubrication, and local estrogen. In case of mother, it can result in increased postpartum pain, impaired mobility. This will impact the breastfeeding due to pain, sexual dysfunction, and predisposition to pelvic floor disorders, and there is a lot of psychological trauma associated with it. If episiotomy is delayed or ineffective, this can result in prolonged second stage of labor, birth asphyxia, increased risk during instrumental delivery. If performed early and judiciously, it can help reduce the fetal hypoxia and birth injuries. What happens after that? So there will be perineal scarring, which will result in less elasticity and risk of tear. Previous voices, which can cause risk of recurrence, may need elective LSCS, pelvic floor weakness, incontinence risk, and psychological trauma resulting in fear of perineal pain. The alternatives include perineal massage, warm compresses, controlled head delivery, hands-on support, maternal positioning, lubrication, and avoiding early pushing. The current recommendation, WHO and FIGO recommends restrictive use of episiotomy only in 10 to 20% of the vaginal births. Avoid routine use except under clear indications such as instrumental delivery or fetal distress. To summarize, episiotomy is a surgically planned incision on the perineum during the second stage of labor to enlarge the vaginal opening and facilitate a controlled, safer delivery in selected situations. Modern obstetrics recommends only a restrictive approach. Mediolateral type is the most common used in India as it reduces the risk of anal sphincter injuries, while midline type is associated with easier repair but high chances of extension. Episiotomy is indicated in circumstances such as fetal distress, instrumental delivery, preterm delivery, or rigid perineum, but it also poses risks such as bleeding, infection, hematoma, wound dehiscence, dyspareunia, pelvic floor weakness, obstetric and sphincter injuries. Management focuses on controlled bleeding, treating infections, evacuating hematomas, and repairing any extension or gapping. Long-term effects may result in chronic pain, sexual dysfunction, pelvic floor disorders, women with previous severe perineal tears, and altered delivery planning in the next pregnancy. I hope you have learned during this presentation. Thank you for watching.